Good to see everybody. Good to see everybody this morning. Our speaker this morning, Dr. Christine Neeb, one of our newest faculty members, Associate Professor of Medicine in our division, coming to us from University of Illinois at Chicago. Dr. Neeb went to College of Middlebury and did medical school at University of Rochester, and then residency in family medicine at University of Illinois at Chicago. Spent a number of years in federally qualified health centers and developed an interest in addiction medicine and has developed expertise in introducing addiction medicine or addiction management in primary care practices. And we've got her here now to help us with that significant problem. And she'll be speaking with us today about safe opioid prescribing. So Dr. Neeb, thank you so much for joining us.
All right, thank you so much. So today we're really going to be focusing on safer opioid prescribing. Of course, there's no such thing as totally safe opioid prescribing, and really focusing on the difference between the 2016 and the 2022 CDC guidelines for prescribing opioids. And this, as I am an addiction physician, this is going to be more focused on that addiction lens. So particularly reducing risk, reducing misuse, reducing diversion, and helping our patients to make the best decision for themselves. So I always like to start with just what are the risks of long-term opioid therapy? Because I think a lot of times when we talk to our patients, we focus on what is the risk of opioid use disorder and what is the risk of overdose. And for a lot of our patients, they have been on opioids for 10 years, 20 years. They are not misusing their opioids. They're taking exactly what we're prescribing to them. And so when we talk to them about this, they're kind of like, yeah, that's not me. And that's true, that's not them. But we kind of, a lot of times we don't focus on these other side effects that do affect them. So the risk of fractures, especially as our patients get older, a lot of neuroendocrine dysfunction, hypogonadism, low testosterone, erectile dysfunction. Central sleep apnea is a huge one and can develop over time. So we want to make sure that we're paying attention to that. Our patients might not have had sleep apnea when they started on opioids, but now they do. Cardiac effects and cognitive dysfunction are major issues as our patients age, and then just an increased all-cause mortality. So our first recommendation from the CDC sounds pretty simple, right? Non-opioid therapies are at least as effective as opioids, and we want to try to maximize those non-pharmacologic and non-opioid therapies as much as we can. Unfortunately, that doesn't happen as much, right? Like a lot of times our patients come in, they're like, oh, I can't take Tylenol. Tylenol doesn't work for my pain. Ibuprofen doesn't work for my pain. And we're so used to it that sometimes we just are kind of like, okay, fine. Yeah, oxycodone works for you. But really we have to have that risk benefit discussion and look back at what our patients are saying are their contraindications and see, are they really contraindications, and what can we do to try to help them to reduce their risk as much as possible. I think, of course, acetaminophen is a big one. A lot of times we forget that even in severe liver disease, we can give our patients up to 2 grams per day of acetaminophen. We also want to make sure we have that 2-gram max if they're actively consuming alcohol. NSAIDs are, so many of us have had that patient says, oh, I can't have NSAIDs, because 10 years ago I had an ulcer. Well, that was 10 years ago, and their risk right now might be much lower. And so we want to make sure that we really thoroughly look into that, along with chronic kidney disease, because there might be a risk to the NSAIDs, but there's a lot more risks to the opioids. And so we really want to educate our patients on those and help them so that they know that they actually can take these less risky medications and they are as effective as opioids. So if you have a patient who has some of these risk factors for NSAIDs, different NSAIDs are going to have different risks. So for instance, if cardiac risk is one of your patient's major concerns, naproxen might be the better option for them. Whereas, if it's GI complaints, then celecoxib might be a better option. This comes up a lot. So unfortunately, sometimes tramadol will show up on that list of ALTOs, of alternatives to opioid treatment. And it is not. It is an opioid. It is a less potent opioid than morphine. But we just do want to remember that it is in that family. And unfortunately, the reason this came up was because the pharmaceutical company was allowed to market it as a non-opioid because the prodrug is not an opioid, but its active metabolite is. And somehow they were able to get that through and were able to market it in that way. It's about 1/10 the strength of morphine, but it also has other effects as well. So tramadol is also an SNRI. So if you have a patient who is finding a lot of benefit from tramadol, then possibly something like duloxetine might be a good option for them as well. I always like to bring this up because I think, sometimes we really forget where oxycodone lies in terms of its potency as an opioid. So this is our morphine milliequivalent conversion chart. Everything is kind of weighted in terms of its relationship to morphine. And oxycodone is 1.5 times the potency of morphine, but about half the potency of heroin. So if you are looking for a pain medication for your patient that is more potent than morphine, but less potent than heroin, then oxycodone might be the right option. I think sometimes we have been so used to prescribing so much oxycodone that we really forget where it lies in this spectrum. And a lot of that, again, is the pharmaceutical company and how they advertised it. So morphine used to be considered kind of like the dirtier opioid, and it does have more side effects, right? So more likely to get nausea with morphine. You can have more renal accumulation. But on the other hand, oxycodone, it doesn't have those side effects as much. So there's not those breaks for the patient. And it also actually has more euphoria than morphine. So not only are we giving our patient a medication that doesn't have side effects that's going to make them want to stop, it's actually going to give them the side effect of euphoria, as well as opioid-induced hyperalgesia when they get to higher doses. So you want to be very cognizant. If you have a patient in front of you who you feel like, okay, this patient is appropriate for oxycodone, but you would recoil at the thought of giving them morphine, you really want to think about that and think about, like, is there a true medical reason for this, or is this kind of the bias that we've been left with from Purdue Pharmaceuticals and how they advertise this medication to us? So our next recommendation from the CDC, so non-opioid therapy is preferred for subacute and chronic pain. And again, I think a lot of times we know this, but we're not necessarily having that conversation discussing the realistic benefits and known risks of opioid therapy. So if our patients are having chronic pain and we decide that it is appropriate for them, we really want to make sure that we're setting the correct expectations and focusing on function. Pain is going to be a normal part of their life if they have chronic pain, and we want to make sure that we're focusing on what are the functional benefits for the patient, what are their goals, and writing those down so we can go back to them later if the patient is not getting the effect that they need. Of course, non-pharmacologic treatments, we know what these are, but a lot of times we just kind of like skate by them with the patient because that's, they're hard. Sleep is super important. Our patients are going to continue to have worse chronic pain if they're not getting good sleep. Same thing with exercise. We want to make sure that our patients remain functional, and, going through a chart like this and having your patient just pick one or two can sometimes be helpful. So the non-opioid medications, there are a lot of them. We're just going to go through which one of these have more evidence. So the SNRIs, pretty good evidence for these. So medications like duloxetine have good evidence for neuropathic and musculoskeletal pain, and tricyclic antidepressants as well. The issue with this, right, is that once our patients have tried opioids, it's really hard to convince them to give something like this a chance. So again, we're talking about starting opioids or other medications for chronic pain. We really want to kind of go through all of these options before we decide, okay, none of these are working. Now let's try an opioid for chronic pain, because your patient is going to have a lot more buy-in into waiting that several weeks to see if this is effective if they haven't already gotten that immediate gratification from an opioid, which, as we know, is going to be immediate at first, but then they're going to develop tolerance and it's not going to work as well later. Gabapentin and pregabalin or Lyrica, so we use these a lot. Really limited benefit or limited evidence, and it's really only approved for certain types of pain, so neuropathic pain. So we do want to be careful. A lot of patients end up on really, really high doses of gabapentin, which do have a lot of side effects as well. But for neuropathic pain, it can be quite helpful. I think these alpha agonists, so these are often underutilized. They can improve central pain modulation, also can be helpful if your patient is going through an opioid withdrawal. But clonidine and tizanidine, so tizanidine, we often think of that more as a muscle relaxant, but it is more of an alpha agonist. Muscle relaxant. So I feel like when our patients come in, they have back pain and what they want is some oxycodone and some Flexeril or some kind of muscle relaxant. And, these are some of the medications that don't really work that great for musculoskeletal pain. So tizanidine actually is one of the ones that I would recommend if your patient really wants a muscle relaxant. Baclofen, more for like those true spasticity disorders. One of the ones to really try to avoid would be carisoprodol or Soma. So this medication, one of its metabolites is mepromabate, which has benzodiazepine-like effects. So really want to try to be careful with that, especially if your patient is also taking opioid. Low-dose naltrexone, also really underutilized, I think a lot of times because it's challenging to prescribe. So when we talk about low-dose naltrexone, we're talking about like 1 to 5 milligrams a day. So you have to get it out of a compounding pharmacy. This is as opposed to like the dose that we use for alcohol use disorder, which is like 50 milligrams, 100 milligrams. The mechanism seems to be modulating those neuroinflammatory pathways, and there is some promise in reducing pain in fibromyalgia, MS, and some inflammatory bowel conditions. And I can say that personally, I've had patients with fibromyalgia get a lot of benefit from this, and they were really surprised, and so was I. So marijuana or cannabis comes up a lot, right? Our patients often really want to try this. There's been a lot of studies on it, hopefully more once we can get the scheduling changed on the cannabis, but really limited evidence that it will relieve some neuropathic pain in some patients, but not for general chronic pain. There's not a lot of evidence for it. And it also has those associated increased risks of adverse mental health effects, particularly anxiety. So we want to be really careful in the patients that we're recommending that to, and really talk to our patients if they're going to try it anyways, what are the risks and benefits and what can they expect from it? Similarly, like a really large Cochrane study came out looking at 16 studies, 1,750 patients, and found that, again, not a lot of benefit. And they also, most studies excluded patients with substance use disorder. So if your patient does have a substance use disorder and they're like, oh, I want to avoid opioids because I have a history of opioid use disorder, be aware that all these studies around cannabis really didn't look at those patients. So we don't know for sure what the effects would be on them. So go through all these non-opioids, patients still want an opioid or they think it's going to work for them. Does it work? And we've had tons and tons of studies looking at, are opioids effective for chronic non-cancer pain? This is one meta-analysis that was done. It's very minimal, right? So there was a very small, but it was statistically significant improvement in pain and functioning, but there was an increased risk of side effects, including vomiting. So it's not that it's not going to do anything at all, but given all the risks that we already know about, trying all those medications beforehand, before you even introduce your patient to an opioid, is generally the recommended way to go. And so if that's the case, if it's not very effective, if there's a lot of side effects, why are our patients constantly telling us this is what works for me? Only oxycodone works, only opioids work. I need this medication. You can't take me off of it. And so they did look at this. They did a randomized controlled trial of over 600 patients with chronic pain who are using opioids. And while patients reported pain relief as the initial reason to get that prescription, over half, once they've been on chronic opioids, were reporting that avoiding withdrawal was their primary current reason for use. And the second most common reason was pain relief. And then the third was euphoria. So, and this is of patients who are aware that they are using it for withdrawal, right? A lot of our patients have no idea what withdrawal is, and all they know is that when they stop their opioids, they are in a lot of pain. And pain is one of the main symptoms of withdrawal. It feels terrible. And so if you're a patient, you're like, I stopped my medication, my pain was really bad, I took my medication, it went away, of course that's what you're going to think. And it's really our job as physicians to talk to them and help them understand it, really kind of dig deep into what their symptoms are, and warn them what withdrawal feels like so that they can have a better understanding of what is actually happening to their body. So our next recommendation from the CDC, pretty simple. We want to prescribe immediate release opioids and not extended release or long-acting opioids. And the reason for this is just that there's just an increased risk of toxicity and overdose when you prescribe those long-acting opioids. They're more likely to build up in your system, and there's not really a difference in pain relief. This is one of the big problem recommendations from the CDC. So back in 2016, they had recommended these kind of caps on the MMEs, and physicians took this really, really seriously. And the pendulum swung really far in the other direction. A lot of patients were taken off, were titrated down really rapidly, and it caused a major problem, which we'll get into. So the new recommendation came out in 2022 that you just want to prescribe the lowest effective dosage and carefully evaluate the individual risks and benefits to the patient when you're going to consider increasing it. And what was the reason for writing that initial recommendation? What was happening was that we just kept prescribing more and more and more medication, right? Like the patient would come in, they would say, you know, the oxycodone isn't working as much anymore. And you're, okay, great, higher dose, higher dose, higher dose. And they were trying to prevent that cycle, but ended up creating a lot of problems in the meantime. And one of the issues that was happening and still is happening is this confusion between chronic pain, addiction, and what is becoming more and more known as complex chronic pain and opioid dependence. So you can definitely have an overlap between chronic pain and addiction. It's super common and it's really hard to treat, right? But that is not the same thing as when your patient has chronic pain and develops opioid dependence. And we really want to make sure that we navigate this because the treatments are going to be very different. So a patient with chronic pain and addiction, probably like buprenorphine or methadone is going to be an appropriate treatment for both of those issues. Whereas when your patient is having chronic pain and opioid dependence, you start to decrease that opioid medication. They go into withdrawal that's going to trigger this chronic pain cycle. And now you're thinking, oh gosh, like every time I try to, you know, reduce this patient's opioids, they are coming in, they're asking for more drugs, they're drug seeking, quote unquote. And, you know, now I think they have an addiction. Well, really, you know, this is just a normal human physiologic response to the opioids we've been prescribing them. And we'll get into all the risks that come along with trying to take our patients with chronic pain off of opioids very quickly. Some of you might have heard of this idea of pseudo addiction. So this again is that patients who have chronic pain that is not, or acute pain that is not being treated appropriately are going to look like patients who have addiction. They are going to be asking for higher doses. They are going to be running out. They are going to be potentially borrowing medications from friends or buying it off the street. And really this, I feel like, is more of a provider problem than a patient problem. We see these patients and then we label them as drug seeking, and we say, you know, the problem is them. The problem is that, you know, they don't know how to control their use, when really we are not paying attention to the fact that our patients are developing tolerance and withdrawal because of a medication that we prescribed. So we really want to be careful. Just because our patients check off those DSM-5 criteria doesn't necessarily mean they have a substance use disorder. We really want to delve into that withdrawal tolerance cycle and pain and how that they might be contributing. So one of these recommendations from the CDC, back in 2016, there was nothing on this, and this was a totally new one that they had to come out with, again, in response to that pendulum swing where we took a bunch of patients off of all their opioids. And basically what this says is that you want to weigh the risks and benefits when you're increasing or changing the opioid dosage, and you do not want to discontinue it abruptly or rapidly reduce their opioid dose from higher dosages. And if you guys remember back when these the 2016 guidelines came out, there was just a huge backlash. Patients were rapidly taken off their medications, and there were a lot of unintended consequences. A lot of patients were in pain. A lot of patients couldn't get their medications, couldn't function. There was increase in suicide risk. And that's what caused the CDC to initially just put out an alert, just an update, and then they ended up having to redo the entire guidelines a few years later. And before we get into the risks of taking patients off of their opioids, I just want to focus on the waves of the epidemic, right? Because I think a lot of us have seen this graph. And the thing I want to point out more than anything is that at this point in time, prescribed opioids are not what is driving the epidemic. And that is even more apparent if you look at the Colorado numbers. So back in 2000, it was the oxycodone crisis. Now it is the fentanyl crisis. And that is what is driving our overdose deaths. That is not to say that patients don't start oxycodone and then transition to heroin or fentanyl as they develop a use disorder. They definitely do that. And so that's why we want to really avoid that very first prescription or that second prescription. We want to avoid diverting it into the community. But our patients who are taking the medications that we're prescribing for chronic pain, that is not, even if we got rid of all of those, even if we tapered everyone off of their medications, we're still going to have an overdose crisis. And so, I think we're trying to unwind the clock and try to fix something that happened 20 years ago in order to fix the current crisis. And that's just not what the current crisis is. So what does happen when we try to reduce or discontinue long-term opioid therapy in our patients? This meta-analysis looked at all the different strategies for reducing or discontinuing long-term opioid therapy for chronic pain, and really just found low-quality evidence that reducing their opioids improved their pain, improved function, or improved quality of life. So we're asking patients and this is again patients who are on opioids already. We're not talking about starting them on opioids. They come to you, they've already been on it. We're asking them to do a lot and go through a lot of work for maybe not great benefit at the end of the day, at least to them, in terms of their pain and their function. So what does happen when we discontinue them? Well, there's been a lot of studies on this. This study looked at a retrospective study in Vermont, looking at patients who were rapidly tapered off of their opioids. So that was most of them were within 21 days. Almost half, 49% of patients had an opioid-related hospitalization or ED visit, compared to patients who were not tapered off of their opioids. So they're ending up in the ED, they're ending up hospitalized. One of the really sad findings from this study was that 60% of those who were tapered had a diagnosis of a substance use disorder, but less than 1% were actually transitioned to a medication for opioid use disorder. So they were taken off of all their opioids and then kind of just left, and were not transitioned to what is the gold standard of treatment, which would be a medication for opioid use disorder. So we looked at that first slide that said that all-cause mortality was going to increase when you start patients on opioid compared to patients who have never been on opioids. Now, when patients are on chronic opioids for however many years, if you discontinue their opioid therapy, it doesn't reduce their risk of death. It actually increases their risk of overdose death. So in this retrospective cohort study, almost 5% of patients who were discontinued died of overdose, while less than 2% who were retained died of overdose. So mental health risks, again, we think of being on opioids, that increases your risk of anxiety, increases risk of depression. But when we take patients who are on chronic opioids and we taper them off, they are at increased risk of death from overdose or suicide. And that risk increases the longer they've been on their opioids for. So this study, huge study from on VA patients, almost 1.4 million subjects. The hazard ratio for stopping opioid treatment was 1.67 for less than 30 days of treatment, and increased to 6.77 for over 400 days of treatment. And then, one of the things we always talk to our patients about again, when we're talking about the risks, your risk of developing an opioid use disorder when you're on opioids. This study looked at patients' risk of transitioning to non-prescribed opioids or heroin and found that patients who were discontinued from opioids were more likely to use heroin or non-prescribed opioid pain relievers than those who had unchanged prescriptions. So now, right, you're probably like, well, what do you want me to do? You spent half of this presentation saying how bad it was to be on opioids, all of those side effects. And now you're saying that if I take my patient off opioids, they're going to be at an increased risk of suicide, an increased risk of hospitalization. And the answer is, yeah, it's really hard, right? We want to try to avoid that very first prescription, because once we get into this legacy opioid category of patients who are on chronic opioids, they don't have great options. Both options carry risk, and we're not really even talking about a risk-benefit discussion anymore. We're talking about a risk-risk discussion. And so what does that look like? So when patients come to me on these medications, I really try to come at it from without having any agenda as to whether I want them on an opioid or not, or I want them to come off of it. Because as we saw, it's risky either way, and we really need to follow the patient's lead in terms of what they think is going to be best for their functionality, for their life. So I try to go through those that list of side effects, focus on the ones that really do affect that patient. So if they're hitting, age 65, if they've had falls, if they have a history of, Alzheimer's in their family, I'm going to focus on those risks that maybe apply to them the most and help them compare their treatment options and help them come to a decision. And again, this is for patients who do not have a use disorder. This is just for your patients who are on opioids. They take what you prescribe. They're not using anything non-prescribed. They're not really engaging in those high risk behaviors or using other drugs and alcohol. Because at the end of the day, either way carries risk, and we want to make sure that our patients are doing what they feel is going to help them be most functional. So again, that super long list of side effects from opioids, I usually just pick out 1, 2, or 3 and focus on them in my discussion with the patient, whatever seems to be the most relevant to them. Okay, so recommendation number 6 from the CDC, prescribing no greater quantity than needed for the expected duration of pain severe enough to require opioids. Again, sounds very basic, but we don't do it. A lot of times we do a lot of just in case prescribing. So, the patient came in with, a broken finger, broken arm, pancreatitis, whatever it was. And even though we know logically they probably only need 2 or 3 days worth of opioids, we're giving them 2 or 3 weeks worth of opioids. I don't want them to call and bug the nurses. My schedule is full for weeks and weeks and weeks. I'm not going to be able to get them back in. But really all that's doing is giving your patient the option to continue to take opioids when they do not have severe pain anymore. So it gets them used to this idea that an opioid is just a normal medication for pain, or they end up with this medication just sitting in their medicine cabinet, and now they can just take it several months later when they have a headache or, they sprain their ankle. Or it gets diverted into the community when, a child, a partner, a grandchild ends up taking it out of the cabinet and using it non-prescribed. We also want to make sure that if our patients do end up taking opioids around the clock for more than a few days, we look into a taper. And we will get into this, but if they are continued on opioids more than a month, we really need to sit down and have that conversation about, we're transitioning into opioids for chronic pain. Is this something that you really want to do? And is this something that is medically appropriate? So once the patients are, once you're hitting that 1 to 4 week mark, we really need to start reevaluating the benefits and risks of continued opioid therapy. And unfortunately, this is the time that we often don't see them, right? Because we just saw them for this acute pain issue, whatever it was. We gave them the prescription, we sent them home, our schedules are full. But really, we want to do more frequent follow-ups so we can reassess the pain and talk to them, because it sneaks up on us, right? It was one prescription and then another, and then they got a refill. And now all of a sudden, before I know it, this patient who was in a car accident and who had a back injury has been on opioids for 3 months, and I never talked to them about what it really means to be on chronic opioids. So want to make sure that we're having those conversations. We're going through those lists. We're trying to reverse any potentially reversible causes, addressing mental health disorders as well. Depression and anxiety contribute hugely to pain, and maximizing those non-pharmacologic and non-opioid treatments as well. Regular assessment, super important. They should at least be being assessed every 3 months, if not more frequently, especially at the beginning of treatment. So when we assess our patients, right, some of us are so used to this pain. What is your pain? 0 to 10. This is not very helpful, right? Because our patients are always saying 8, 9, 10, 12. There are actual validated pain assessment scores. These are 4 of them that are actually in EPIC. I like this one. I think this is the Pain Disability Index. And it really goes through a lot of the behavioral health stuff. So like, are they depressed or anxious? Because we really need to address that. Sleep, again, one of those things that we really need to address in order to address chronic pain, and their functionality. And it focuses just a little bit on giving numbers for pain. All right, so now your patient is, on an opioid, and we really want to make sure that we are mitigating risk. And I think a lot of us think of offering naloxone as a way to mitigate risk, and it is, right? As long as someone in the house knows how to use it. But there are other things that we can do as well. So using a screening tool. So we will talk about toxicology screening, but just asking your patient if they're using alcohol, using benzodiazepines, any other respiratory depressants, and having conversations about that, making sure that we're treating them for depression and other mental health conditions. Our patients are aging, right? So once they hit that 65-year mark, we really want to start paying attention, because we might be giving them the same dosage of opioids, but their renal function and their hepatic function are declining. And so they could be experiencing more side effects from the medications. So the PDMP, the CDC put out a very specific recommendation to make sure that we are reviewing their history of getting prescribed controlled substances. And I think a lot of us do this. We click that box in EPIC, but really we need to act on what we're seeing in there. So we want to check before that initial prescription, and at least every 3 months, preferably with each prescription that we write. And one of the biggest things is this is not meant to be punitive. This is meant to be a safety feature. So we don't want to dismiss our patients from our practice because they did something that we told them not to do. Our patients are always doing things that we tell them not to do. This is just more information for you to gather, and it might result in you not prescribing that opioid, right? So that co-prescribing opioids and benzos carries a huge risk. And so you want to catch that very first time that patient gets prescribed a benzo, because that is the time, hopefully before they've developed a dependence on the benzodiazepine, that you can say, look, you cannot have both of these. There is not a medical reason right now for you to be on both an opioid and a benzo. So you need to make this decision. If you want to continue to get this benzodiazepine from this other prescriber, we need to taper you off this opioid. And you can, at that point, it's easier to set a line before they are now on chronic opioids and chronic benzos. And now you're really in a tough spot. So the toxicology testing, another one that we use, but often we don't necessarily know what to do with it. So toxicology testing is, the urine drug screen, right? So our recommendation is typically, if there's no red flags, to be getting this annually on all patients. And I think one of the things that's very, very important for toxicology screening is making sure that we are using this tool on everyone equally. So we want to try to minimize our bias as much as possible, because what ends up happening, right, is we have rules, or we have, a clinic guideline as to how often to utilize toxicology testing, but then we only end up applying it to patients that we think meet what we think is a patient who is at risk, or who we think is going to abuse drugs. And what we've actually found is that white women of high socioeconomic status are the most likely to not be diagnosed with a substance use disorder, because they come in and we think, oh, look, this person does not fit what I think a person with a substance use disorder looks like. So then when things happen, like they say, well, I can't come in person for this visit because, I have this job or I have to pick up the kids. We think, oh, well, yeah, that makes sense. And so we give them a lot of passes and make a lot of excuses. And then we apply our rules to patients that already meet our biases about what we would expect. And then that, again, will reinforce it for us because we're like, well, I thought that this Medicaid patient would be, using a non-prescribed drug, and they are. Well, if you had tested that other person for done toxicology testing, you might have found the same thing. So want to make sure that we're using on everybody equally and not using it in a punitive manner. So we're not going to dismiss patients from care over the toxicology testing. We might have to not prescribe the medication anymore. We might have to taper it, but we're not going to just not be their doctor anymore, because that is going to end up with them just doctor shopping and potentially ending up in a more high-risk situation. We want to make sure that we actually do something if we have an unexpected result. And an unexpected result can be that drug that we are prescribing is not there. That's very concerning. Or it can be something, another drug that we didn't expect to be there is in their testing. And I think if we are only seeing them every once in a while, it might be 6, 7 months before we get to go ahead and address this in person, and it's uncomfortable. And so at that point, it's kind of over, right? The patient doesn't remember what happened 6 or 7 months ago. And now you've been continuing to prescribe this despite seeing that red flag in the chart. And so it's really hard to actually act on it. So I usually like to make sure if there is anything unexpected, you bring that patient back right away, whether it's in person or just like a phone visit. And I just usually turn the screen to them and say, hey, it looks like you tested positive for an amphetamine that is not prescribed to you. And then you just stop and wait, because they will fill the silence and they will come up with something. And then you can have that discussion. If it is something like a benzodiazepine, for instance, I try not to get into the argument of, did you or did you not take this? I don't want to, this is not about believing a patient. I usually just say it as, this medication is in your body. Because it is in your body, you are high risk for an overdose, and therefore I cannot continue to prescribe this medication, or we need to do something about this, opioid that I'm prescribing. And because I don't want to argue about how it got in your body, about whether you took it intentionally. That's just a kind of a discussion that doesn't really go very well. So the opioid and benzo problem, right? As we all know, this is a major risk. So patients who are prescribed both an opioid and a benzodiazepine, even if they got a former prescription and they're not actively taking both at the same time, they're still at an increased risk of mortality. So the adjusted hazard ratio is 2.33 for just a former prescription. It's 3.86 if they are getting a current co-prescription, and that risk is increasing as their benzodiazepine dose increases. So there are very rare circumstances where it is okay to co-prescribe. Having anxiety and chronic pain is not a reason to co-prescribe, because everybody with chronic pain has anxiety. That's part of the illness. If the patient, say, has a severe trauma or acute pain and they're on a low-dose benzo, fine. A very short prescription of an opioid might be appropriate. The other instance where it is appropriate is if your patient already has a diagnosed opioid use disorder and they're on buprenorphine or methadone, it is okay to continue that and preferable to continue that, because a patient with opioid use disorder is much more likely to die if we take them off of the bup or the methadone. So that is okay. But otherwise, those risks are really high, and particularly very high if patient is using the benzo unpredictably. So those patients who are like, well, I actually only take this Klonopin once a week. That patient is actually at higher risk than the patient who takes it every single day. And sometimes this comes up right when the patient's like, well, I only take my Klonopin once or twice a week. And you look back at the PDMP and you're like, well, but you've been filling it every month for a year. So where did all the Klonopin go? And that's another, discussion to have with the patient, because maybe they are taking it a lot more than they think, or a lot of patients just have like a huge supply of Klonopin in their home. They'll be like, oh yeah, it's all in my bathroom drawer, and they have like enough Klonopin to survive the apocalypse. But that medication is just going to end up being diverted into the community, or they're going to have a very stressful incident in their life and all of a sudden take a whole bunch more Klonopin and put themselves at risk. So our last recommendation, if you do end up diagnosing a patient with an opioid use disorder or a substance use disorder, we need to make sure that we arrange treatment for them, not just stop the medication that we're prescribing. And so it used to be that we would say medication-assisted therapy or medication-assisted treatment. And the idea was that methadone or buprenorphine was just an adjunct to like therapy or counseling or a 12-step program. Now we're really pushing towards this medication first model, because really medication is the only thing that has a proven mortality benefit for opioid use disorder. And particularly it's methadone or buprenorphine. Extended release injection naltrexone has some benefit in terms of reducing illicit drug use, but doesn't actually improve mortality. We also want to make sure that we're not simply detoxing or letting our patients withdraw, as that increases their risk for overdose once they are out of withdrawal. They don't have the tolerance anymore, and they're more likely to overdose. If you are not prescribing buprenorphine in clinic yourself, and you're going to refer your patient to a substance use treatment program, you really want to make sure that you're referring them somewhere that is practicing evidence-based care, because unfortunately, only 1/3 of treatment providers offer methadone or buprenorphine. Most of them are just abstinence only, counseling only, and those are not going to improve mortality. They are actually going to improve survival. They are actually going to increase our patients' risk of mortality. This is just looking at buprenorphine and methadone. They are about equivalent in terms of their efficacy. They increase retention and treatment, reduce opioid use, reduce risk of death, and reduce all-cause mortality. Whereas that extended release naltrexone only increases retention and reduces opioid use, but does not improve mortality. So medications for opioid use disorder, super effective. In 2009, when buprenorphine became available in Baltimore, the heroin overdose deaths in that city decreased by 37%. So if you do have that patient that you think has opioid use disorder, has opioid use disorder, and they have chronic pain, buprenorphine is actually a great option. So transitioning patients from a full agonist opioid to buprenorphine actually improves their initial pain scores. And patients end up needing less morphine mill equivalents when they are transitioned to buprenorphine as well. And the thought behind that might be that opioid-induced hyperalgesia from being on that super high amount of opioids is reduced once we get the patient off that medication. So in conclusion, it is really hard to treat patients who have chronic pain, right? We know that. But we really want to be avoiding that first prescription, because that is where we can make the most difference. Once we have those legacy patients who are on chronic long-term opioid therapy, it's really a risk discussion with the patient. And we want to make sure that our patients are understanding what the benefits are, what the risks are to them, and making the decision that is best for themselves. And then if we do end up having a patient with opioid use disorder, we want to make sure that we get them into the appropriate treatment as soon as possible. Yes.
There's a couple of questions on the chat about your experience with topical therapies. There it is. It says capsaicin and menthol and so forth. What is the utility of the?
Yeah, I mean, I think we can reach for those anytime, right? If you're concerned about the systemic absorption of medication than a topical, it can be really effective. Again, I'm not a pain specialist. I'm more on the addiction side. So that might be a better question for one of our pain colleagues. But I use it pretty frequently. Patients seem to like it. And, if it avoids an opioid, then great. Sure.
You mentioned that we should, not use the PDMP punitively, not use the urine tox punitively. We've got language in our opioid use agreements that doesn't really support that. Should we be adjusting what our agreement looks like?
Yeah, and I've heard it started, sorry? Oh, the question was, because we're not supposed to be using this PDMP punitively or toxicology testing punitively, but our agreements kind of say otherwise. And I would say, yes, we want to make sure that we're using non-stigmatizing language and making sure that patients really don't feel like they're being targeted, because if they end up having a use disorder, we're punishing them for exhibiting symptoms of their own illness. And so we really want to try to avoid that and make the patient feel like they can actually come to us. Like those patients who we saw, over 50% of them are now just using opioids to avoid withdrawal, not chronic pain. But our patients aren't saying that to us because they're afraid that we're going to punish them and just take away the one thing that they know is helping them. So yeah, I'd say that we really need to look into that language.
Naltrexone for the treatment of chronic pain. Can that be done when a person's on an opioid? And two, for someone who successfully tapered off opioids is still miserable, does it have a role there?
Yeah, so the question is naltrexone for chronic pain. If they're on opioids, can it be used? And if the patient has been tapered off opioids and they're miserable, can it be used? It really cannot be combined with opioids. It's not going to do much. Like it's at 1 to 5 milligrams, it's probably not going to throw them into precipitated withdrawal the way a 50 or 100 milligram dose is going to. But really, like the idea is to block at least some of those receptors. So I don't think any of the studies have really looked at whether you could combine them. And my guess would be that it wouldn't be very effective. And then as far as once patients are tapered off, I'd say if you're dealing with that post-taper period and they're really, really miserable, the taper might have been too fast and they might actually do better getting a little bit more opioid agonism through like a buprenorphine rather than completely blocking that with naltrexone. It's really not going to help the withdrawal symptoms at 1 to 5 milligrams.
So along those lines, you mentioned naltrexone for opioid use disorder. Is that going to also threaten withdrawal? Yeah,
so, and that's part of the reason that, I put a little asterisk next to that being a treatment. So in order to treat someone with naltrexone for opioid use disorder, they have to be completely off of opioids for 10 to 14 days, which if your patient is able to stop using opioids for 10 to 14 days, then most of them don't have a severe opioid use disorder. They wouldn't have gotten this, wouldn't be in this situation. So typically, we use injectable naltrexone for patients with opioid use disorder when they're coming out of the carceral system, or if they're coming out of a medically supervised withdrawal or detox. And it, again, does not improve mortality because it blocks the opioid, but it doesn't help the withdrawal symptoms. It helps the cravings a little bit. And so what you end up doing is blockading those opioid receptors. The patient is miserable. They don't come back for their next naltrexone injection, and then they just use opioids. And now that same amount of opioid that they were used to using and basically just made them feel normal causes an overdose because now their receptors are completely naive again. So it's not just that, it doesn't improve mortality. There are some studies showing that it might actually increase mortality.
You mentioned like a couple reasons you would taper a patient and not taper too fast. What would be like a good rule of thumb for how quickly to taper?
Yeah, so if the patient is in agreement, I usually try to go no faster than 5 to 10% per month. And really going at the patient's speed. So if the patient needs to take a break for a while, that's totally fine. And sometimes I think as providers, we get in this mindset, like, I want this patient completely off of opioids. When really, if we can reduce that total dosage by 30%, 50%, that's a huge win for both us and the patient. But you want to really listen to your patient, go at their speed, because if you don't have their buy-in, as you guys know, it's really a miserable process on both sides.
Those lines Is there both on long acting as well as short acting? Which where would we start with first?
So I would probably, if they are on that many opioids, that they're on long acting and short acting, that is really when I get into the discussion of should you be transitioned to buprenorphine for chronic pain? Because at that point, like, is it realistic that this patient is going to be functional without any opioid agonism in their body? A lot of times, no. We're kind of setting them up for several months or years of being uncomfortable. If they did want to just start to taper off, I would probably start with the short actings first. But if you talk to your patient, you might find that, like, yeah, you're giving them short acting and long acting, but they're really taking the short acting around the clock. And then they end up in this situation where they're choosing to not take, or you've taken away some of the short acting, and now that they're going up and down, in and out of withdrawal as part of the taper. So in that situation, you might want to consider, and again, if they're not using benzos, if they're not using alcohol, transitioning everything to a long acting, and then slowly chipping away at that so they don't have to go through those peaks and valleys of withdrawal.
I've never seen the value of them. I don't know how to use them. I don't know if much.
Yeah, I mean, they're only as effective as we use them, right? So if we have them, patients sign it and then we don't implement it, it's not very effective. And patients also know if we're only using that drug agreement to target them. So I think it is effective in terms of, like, it's in case, like, you do have a situation where your patient doesn't want to give you a toxicology screen, or they say that they were never told that they can't take a benzodiazepine and an opioid at the same time. But I agree in a lot of ways, like, we are just kind of using the agreements as like a gotcha moment so that we can, like, do what we wanted to do and, like, not prescribe that medication anymore. But ideally they should be worded away and used in a way that is informing the patient of the risks, and then giving us a little bit of backup in case, like, there is a disagreement and the patient doesn't want to provide tox screening or come in for appointments. Right, that's it. Okay, thank you.